Okay. The time is 8:33 a.m. and the Oregon Board of Physical Therapy is in session.
Roll call, Timothy,
Here.
Aaron,
Here.
Sandra,
Here.
Hoku,
Here.
Michael,
Here.
Susan,
Here.
Erica,
Here.
Dwight,
Here.
for staff, Michelle, present, Sherry,
Here. Sorry.
Kayla,
Here.
Sarah,
Here.
Joanna.
Here.
Thank you. All present, Madam Chair, and we do have members of the public present.
Okay. Thank you for joining.
First on the agenda, as we do at each meeting, is to focus on the statutory purpose of the board to protect the public health, safety, and welfare for all Oregonians by maintaining standards for quality care, professional skill, and competence through the effective regulation of the practice of physical therapy. And with that, Madam Chair, we are ready for the first item on the agenda, the board motions as a result of executive session.
Okay.
Ready?
Yes.
Ready.
In case number PT 844-01/24, I make a motion to issue settlement agreement.
I second the motion.
First and second, and we'll do a roll call vote. Timothy,
Yay.
Aaron,
Aye.
Sandra,
Yes.
Hoku,
Aye.
Michael,
Aye.
Susan,
Aye.
Erica,
Hi.
Dwight.
Aye.
Madam Chair, the motion carries unanimously.
Case number PT 868-04/24, I make a motion to offer settlement agreement to include civil penalty of $5,000 to be stayed upon completion of board specified courses within 6 months and no further violations for 2 years.
I second the motion.
First and seconded, roll call vote. Timothy,
Aye.
Aaron,
Aye.
Sandra,
Aye.
Hoku,
Aye.
Michael,
Aye.
Susan,
Aye.
Erica,
Hi.
Dwight.
Aye.
Madam Chair, the motion carries unanimously.
In case number PT 780-10/22, I make a motion to reject settlement offer.
I second the motion.
First and seconded, roll call vote. Timothy,
Aye.
Aaron,
Aye.
Sandra,
Aye.
Hoku,
Aye.
Michael,
Aye.
Susan,
Aye.
Erica,
Hi.
Dwight.
Aye.
Madam Chair, motion carries unanimously.
In case number PT 780-10/22, I make a motion to offer settlement to include a minimum of 3-year suspension and completion of board-approved boundaries courses, followed by 3-year probation period requiring board-approved supervision.
I second the motion.
Motion first and seconded, roll call vote. Timothy,
Aye.
Aaron,
Aye.
Sandra,
Aye.
Hoku,
Aye.
Michael.
Yay.
To clarify, nay?
No, aye.
Aye, thank you. Susan,
Aye.
Erica,
Hi.
Dwight,
Nay.
Madam Chair, the motion carries.
In case number PT 801-03/23, the board considered licensee's request to vacate stipulated final order, and I make a motion to take no action in regards to the stipulated final order.
I second the motion.
First and seconded, roll call vote, Timothy,
Aye.
Aaron,
Aye.
Sandra,
Aye.
Hoku,
Aye.
Michael,
I was saying yes. I think I'm not getting my mute off fast enough.
thank you, Michael. Susan,
Aye.
Erica,
Aye.
Dwight,
Aye.
Madam Chair, motion carries unanimously.
In case number PT 853-04/24, I make a motion to offer settlement agreement for surrender of license.
I second the motion.
Motion first and seconded, roll call vote, Timothy,
Aye.
Aaron,
Aye.
Sandra,
Aye.
Hoku,
Aye.
Michael,
Aye.
Susan,
Aye.
Erica,
Aye.
Dwight,
Aye.
Madam Chair, motion carries unanimously.
In case number PT 880-11 or 11/24, I make a motion to close the case and issue license.
I second the motion.
Motion first and seconded, roll call vote, Timothy,
Aye.
Aaron,
Aye.
Sandra,
Aye.
Hoku,
Aye.
Michael,
Aye.
Susan,
Aye.
Erica,
Aye.
Dwight,
Aye.
Madam Chair, motion carries unanimously.
In case number PT 874-08/24, I make a motion to close the case.
I second the motion.
Motion first and seconded, roll call vote, Timothy,
Aye.
Aaron,
I've recused myself.
noting the recusal, Sandra,
Aye.
Hoku,
Aye.
Michael,
Aye.
Susan,
Aye.
Erica,
Aye.
Dwight,
Aye.
Madam Chair, motion carries.
In case number PT 860-05/2024, I make a motion to close the case.
I second the motion.
Motion first and seconded, roll call vote, Timothy,
Aye.
Aaron,
Aye.
Sandra,
Aye.
Hoku,
Aye.
Michael,
Aye.
Susan,
Aye.
Erica,
Aye.
Dwight,
Aye.
Madam Chair, motion carries unanimously.
Any other cases?
Yes. In case number PT 859-05/24, I make a motion to close the case.
I second the motion.
Motion first and seconded, roll call vote, Timothy,
Aye.
Aaron,
Aye.
Sandra,
Aye.
Hoku,
Aye.
Michael,
Yes.
thank you, Susan,
Aye.
Erica,
Aye.
Dwight,
Aye.
Madam Chair, motion carries unanimously.
In case number PT 876-09/24, PT 878-09/24, and PT 879-10/24. I make a motion to ratify the administrative closure of these cases.
I second the motion.
Motion first and seconded, roll call vote. Timothy,
Aye.
Aaron,
Aye.
Sandra,
Yes.
Hoku,
Aye.
Michael,
Yes.
Susan,
Aye.
Erica,
Aye.
Dwight.
Aye.
Madam Chair, motion carries unanimously.
Thank you.
Next item on the agenda is the consent agenda. This is comprised of the minutes from the prior session, the ratification report of licenses issued, and then the director's report and financial statements for the period of September and October. One of the couple of highlights on the report, skipping forward to that, just a reminder, because we are in the second year of the biennium. The total for the biennium is the third table down below on this page. So the first section doesn't change because that first fiscal year is complete. So you see the second fiscal year to date and then the total to date for the biennium. One other highlight, I wanted to bring your attention to the application submitted for this period. If we look at the historicals for endorsement applications, you can see that we are a little bit low relative to the typical trend for October relative to October 2023. So something for us to watch to determine if that is a factor of overall trends or potentially, moving back just one page, a reflection perhaps of the shift that we're seeing to the uptake in compact privilege purchases into Oregon. I'm going to skip forward 2 pages to show you another view of that, where they're coming from. And you can see the pretty steady year-over-year growth that we're seeing in compact privilege purchases. I did incorporate into the report the dashboard based on the agency-wide expectations. In the next meeting, I will probably break this out as a separate page because it ends up making the table a little small in the portrait mode. I had indicated at the September meeting that we had some yellows. We did complete those that were due by the end of September at the time. And the only item left for this particular calendar year is the succession plan update that's due at the end of December. Fully expect that that'll be submitted on time, but since it hasn't yet been submitted by the time of this meeting, we are reflecting that as yellow. The other highlight that I wanted to give is in the employee satisfaction survey, our agency score for the Board of Physical Therapy is a 4.92 out of 5. This is the same numerical value that we had on last year's total score. And one piece that I'm pretty proud of is that our agency score is the highest currently in the state of all agencies of any size. So appreciate that. And we can reference it when we talk about the Federation, but just again, a shout out to Sherry Peru, who received the McDougall Long-Term Service Award and had that recognition at the annual meeting at the end of October. And some other highlights that we have relative to administrative functions that get listed there on the agenda. So congratulations again, Sherry. The rest of the documents are the financials for September and October. And with that, Madam Chair, I will pause to see if there's questions or any corrections on any of the consent agenda items.
I just would like to congratulate Sherry. I was able to log in and listen to her accept the award and her speech, and she did a wonderful job. And go Oregon, go Sherry.
Thank you, Erica.
Congratulations, Sherry. And I'd like to say, Michelle, a 4.92 on that score that's a phenomenal score for your team. So well done, team.
It's a great team. I feel very lucky to work with the folks that I do. Okay, if no corrections or questions on those materials, Madam Chair, you could entertain a motion.
Sandra.
Wake up. I move to approve the consent agenda items as written.
I second the motion.
Motion first and seconded. Roll call vote. Timothy?
I approve. Yes.
Aaron?
Yes.
Sandra?
Yes.
Hoku?
Aye.
Michael?
Yes.
Susan?
Aye.
Erica?
Aye.
Dwight?
Aye.
Madam Chair, motion carries unanimously. At this time on the agenda is an opportunity for public comment. If there's anyone attending that would like to make comment to the board, if you use your raise hand feature. Okay. Madam Chair, I'm not seeing any raised hands or visual cues for comment at this time.
Move forward.
Next item on the agenda would be any delegate reports for the PTCC or the Physical Therapy Compact Commission or the FSBPT, Federation of State Boards of Physical Therapy. If any of the delegates or committee members want to make report, I'll say that the next item would be discussion of the annual meeting, so it would be for any other updates.
Yeah, I can provide an update on the compact committee. We do have an upcoming meeting December 16th. But there has been a little bit more conversation, but no final determination of what would be considered a flagging for investigatory information with the compact compliance committee, but there is some direction with a definition that's moving forward, but it hasn't just quite yet been approved yet. So once we once I get that information, I'll share it next time.
That's great, Erin. Thank you.
I had a really quick thing that sort of related to the annual meeting, but not. On the 6th of November, I gave a webinar with a couple of the other members of the Sexual Boundaries and Misconduct Committee that was geared towards students specifically. It was very well attended. We had what looked like 285 people attending, but actually when we went out to one of the PT programs the other day, they told us they had their entire class watch it together. So that was, 50 people logged in as one. So it went really well. We really were excited about that many students really wanting to hear what we had to say. And I didn't even tell Michelle this yet, but they reached out to us this morning and said, hey, would you like to present this at another meeting? Because they were so happy about the content that we're getting out there to students with the videos that we produced. And we're still producing a few more. So I was really happy to see that go as well as it did, because we had no idea if 2 people were going to show up or, 200. So that was great, especially the day after the election and right after the annual meeting.
That's great, Sherry. And my understanding is that that's intended to be a recorded webinar that would be available to students and to schools in the future.
Yes, that's true. And they're actually putting, I just got an email this morning, they're doing something for the next FSPBT news brief, like a summary of it.
Great. Then speaking of the annual meeting, which was the very end of October, beginning of November. And of course, Michael and Aaron are our delegate and alternate delegate. And picture here, you see Sherry with the McDougall Medal that is received as part of that honor. So at this juncture, I wanted to ask if Michael or Aaron wanted to give any highlights of the meeting.
Yeah, I could start and then maybe Aaron can fill in the blanks. Can you hear me okay?
Yes.
Very good. So some highlights from my perspective. So continuing competencies, there's a document guidelines for professional development that's on the FSB PT resource page that includes well-being, but also practice level things. And they're working on a healthy practice self-assessment. Not just well-being, but in that whole scheme of how we develop as professionals. So I think that'll be a good thing. A model of 19 entrustable professional activities, for example, like informed consent, performing an exam, concluding an episode of care, completing a handoff, and then competencies, 8 of them within the person was shared as an opportunity to frame competence and might eventually replace the clinical performance instrument in schools and be a helpful way for us to frame. That's not a decision. I think that concept's also been floated at the Educational Leadership Conference and in APTA venues. Dry needling competencies, 2024 report is posted on the website. The task force has done a draft of competencies with the final KSRs, so knowledge, skill, I'm not sure what the R stands for, responsibility. Term protection, so coming soon for dry needling. Term protection, so November, so just this month, agreement to pause discovery pending possible discussions between Lifetime Fitness and FSB PT and APTA. But what I understood was this is likely to continue well into 2025. That particularly of note, maybe for the board and context, the FSB PT board would like insights on complaints, if any consumers have complaints about confusion with the DPT labeling. Ethics and Legislation Committee published a standard of care and reasonable and prudent resource document that's available on the FSBPT resource page. So, I think just like reinforcing there's a ton of information on the resource page available to everyone. And so it's great to be aware of that. There's a regulatory hour that's coming up December 18th. Presentations on AI and how it relates to regulation, which is certainly an emerging area of practice. Like disclosure, do you know if you're interacting with a human or not? And when is it physical therapy or not? So I think some things that we'll want to deal with. I mean, what I heard was the avenues for enforcement, you know, depending on what's in the statute at the jurisdiction level would be consumer protection or attorneys general office. So Sherry's work with the sexual misconduct and boundaries, they have done so much work in the last year with a ton of resources on the resource page. So there's an informed consent task force, and they shared a draft definition. I think that goes to the FSBPT board. And so that should be coming soon. Other thing that I thought was interesting, so there is, bear with me just a second. The Extra Mile Conference, and I'm trying to remember what state this is from, but one of the boards in a state put on an Extra Mile Conference. And so they invited payers like Blue Cross Blue Shield, insurers like HPSO, like liability, people from Medicare, Medicaid, addiction. I think Sherry might have been there, legislators, and it was a 2-day session and interactive conference giving PTs half of the required CE for the year. But really, this was a forum for licensees to talk to the board outside of an investigation by the board. I don't know, Sherry,
Yeah, I can add a little bit. So it actually hasn't happened yet. It's happening at the end of January, and it's Louisiana, and I am going to be one of the speakers. And I'm really excited about it because they are bringing in a lot of the speakers, like you mentioned, to really hear from licensees to think like what can we do differently, or what kind of questions you have, sort of a big open forum, but a lot of really great educational content that they're presenting in this 2-day conference. So I'll be presenting on the first day, but I'm going to stay for the whole thing.
I just found that as an exciting, we kind of think back to Nancy Kirsch's challenge to us in preventative regulation. And I thought that was a really innovative thing that, maybe we consider in the future.
It's put on by the board and the professional organization together.
Okay. Erin, Michelle, Sherry, anything else that?
Yeah, I thought it was just amazing the amount of resources are available. This was the first time I'd gone to this meeting, and I was blown away just by the meeting itself. I was able to attend a course specifically regarding or talking about also PT-PT relationships and about the importance of communication between PTs and PTAs. And they called out that, there should always be trust and respect, communication between those teams. And sometimes often when PTA supervision can become in conflict with each other, or a problem is when communication and respect and relationships aren't formed between the PT and the PTA. And I just really appreciated that education. And then I think there was also a presentation, I don't know if this information is probably published somewhere else, about student debt, students coming out of college with student debt, and really a really deep dive, more than I've ever even thought was available, of information regarding the impact of getting a DPT, the amount of debt that people come out of school with, and the cost of college. Was really fascinating versus looking at comparing wages. So if you ever, I'm not quite sure where that information is published, but I think that's really interesting to look at as a profession. I found that really fascinating. And then also just the conversations surrounding AI, like what Michael was saying, was definitely enlightening. And in my current work, we're transitioning to some AI stuff, and it's exciting, but also a little scary. So we'll kind of see what happens. So I was really honored to be there, and I think if anybody has an opportunity to go, they should. It was great.
And next year's annual meeting will be held in Spokane, and we'll send the dates out, so a little bit easier to get to, at least at the same time zone, which can be nice. And to Erin, to your element, the speaker that was talking about student debt, I know that APTA has some figures about the point at which the cost of education, sort of that inflection point where it becomes too cost prohibitive relative to income earning potential. One of the things, they were going to be publishing an article in a journal soon. So once that happens, we would be able to bring that information back to the board and publish that. In addition to the discussion at FSBPT, I did have the opportunity just to go to an AI in medicine conference earlier this week. And some of the highlights there were also focused on pre-licensure education programs and sort of curricula or skills relative to AI that folks going into health professions would need. So I think what I would envision for the board, if you're interested in the topic, that we could bring that to a future discussion, either external speakers or at least some information to bring those aspects about, I think, student debt in the market, and then also AI in practice, whether from pre-licensure to current practitioners, if that topic is of interest.
Yeah, and just to tag on the connecting the dots on student debt. So I think this was Richard Shields from Iowa, and he's published previous articles, and then they have a survey of students and graduates about including tolerance for ambiguity. And so there's a lot of previously published things, but this connection between debt load and coming out of school already fatigued. You know, are you able to actually practice competently? And what's the effect on your well-being if your debt load is so high that you can't meet expenses? So I think like that's the connection for us as we think about that. I think that sounds great. And then AI, I think like it's happening. I think like it's happening right now. And so I think getting our arms around and being really clear about what's physical therapy and what's not, and then how does AI feed in there. And then you know, I think a lot of what I heard from the multiple speakers was just like the aim from AI is to help to support the standard of care, not to replace the therapist, but to inform decisions made in care. But it seems like a little wild west. So
yeah. Thank you. Madam Chair, with permission, we do now have a couple of members of the Rule Advisory Committee on hand. If it'd be okay to skip ahead to that agenda item and then come back to the rest of this part of the agenda.
Yes, that'd be great. Thank you.
Okay. So the next item that we have is a report out of the work of the Rule Advisory Committee. And I'll give a summary, but I would also offer the floor for comments during this for the committee members if you use your raise hand feature to pipe in at any point when I'm giving this, because I am fundamentally presenting your work. So I want to make sure that I represent it appropriately. The first document, the committee, which met several times and discussed essentially the entire Division 40 of the OAR 848, and line by line talked about where there were some recommendations to you, the board, for possible changes. So the first document puts together and does a summary by section of the division. So as an example here on the page, even back to definitions, some of the feedback was that the definitions for record versus permanent record used throughout the division was confusing. And so the proposed change was to actually remove those definitions, as the distinctions were based on paper, basically. And the sections of the rule where records are referenced were modified to create better clarity throughout the division. And when we get to the proposed rule text, you'll see more detail about that. There was feedback about updating the definition of physical therapy interventions. And part of and in telehealth practice on that, some of that, because it's tied to the way the statute is currently written, changes couldn't move forward. And with telehealth practice in particular, the language that was being proposed out of the MPA, which is the Model Practice Act, was really intended for statutory language. So there's a lot more that needs to happen to look at that section on telehealth practice, and frankly, to Michael's point earlier, potentially use of AI could or remote digital devices might be a factor there as well. Under general standards of practice, seeking more clarity around the meaning of competence, and some feedback of it's not always possible to display a license, so asking for some clarity about what to do, whether it's home health or other environments, and just clarification that the rule actually at this time would allow you to produce it or direct folks to the website for the electronic version of the license. There were some questions about the standards for use of healthcare interpreters. This is related to statute and rules that are governed by the Oregon Health Authority. But there was some questions that were asked about if the practitioner themselves are proficient in the patient's language, if they could serve in this role. And so that was clarified that is allowable. So there was no recommended change to the rule. Standards for record keeping. You'll see changes in here that relate to that concept of record and permanent record. There was also discussion in the second piece about whether or not there should be additional information in the record about in-out times, duration. There was no consensus on those potential additions, and there was some concern that some of them may not be practical or relevant in all care settings. So nothing from that discussion moved forward for additional elements. And the Rule Advisory Committee did look at practices from neighboring states and other standards from Model Practice Act and other sources to try to streamline or remove unnecessary regulatory burden while keeping true to the mission of public protection. The standards for authorization to provide physical therapy services. There was, I think it was referencing 2014. This section was substantively the same, but it was rewritten to pull out that dated reference. And then standards for record of authorization. There were some concerns about referrals and who could take and document those. Also, the current rule language requires or tries to control the actions of the doctor that the physical therapist may not be able to influence or control. And so some recommendations of rewriting it to be clear on what the expectations and accountability were for the physical therapist if working with a provider who wasn't following through with providing the written documentation of the oral referral. Standards for initiation of physical therapy, some requests for some changes in Part 2, the clarification of by reference in a school setting, and additional clarification in some of those sections. You'll see those clarifications in the language. Standards for documentation of an initial eval. Committee generally felt that it was overly prescriptive and difficult to apply in the school setting. And so the language was completely replaced with streamlined language that you'll see here in a minute. Standards for the plan of care. General comments were looking for getting clarity about the difference between what is meant by reevaluation, reassessment, and reexamination. Some members noted that if a POC or plan of care is the EIP in a school setting itself, that the PT cannot, there's a typo there, alter without appropriate consultation with the parent. So some recognition about the applicability in the different care settings. And so minor updates were made in this section. Minor updates for plan of care, for providing treatment specific to reassessment and how that's being used. Standards for treatment by a student PT or PTA. There weren't any comments for that section. There was a minor change made just to remove some redundant language, non-substantive. Documentation of treatment provided, simplified language here. Standards for performing a reassessment. The committee felt that there was generally a lot of confusion in this section about what was meant and how it should be applied. So there was a change from using reassessment to reexamination, and then some updates to timelines and what the 30-day period was tied to. And you'll see that in the rule in just a moment. And then related elements to the standards for the documentation of the reassessment. And then standards for discharge. This one, there was not consensus and probably the greatest amount of difference of opinions between different committee members. So at this time, there aren't any changes or proposed language ready to come to the board. This would be something that the Rule Advisory Committee would continue to work on and bring back to you. And I'll show you an additional document in just a moment. There were also no current changes proposed for screening services or telehealth, as I'd mentioned before, or the community screening. And skip forward one more document. This is an example of, in looking at discharge, the committee did look at this potential option for rule modification that I don't think any of the committee members liked in the example for different reasons. So just some documentation of their thoughts on that. So that's first document is sort of a general summary of their recommendations. The next piece of it is to look at the recommended language itself. So in this, the notation is standard for proposed rule language changes. So you start with the existing language, anything in bold, and we also made it red to make it a little easier to see. That is new language that's being proposed that's not currently in the rule. And then anything that's being recommended to be removed from the current language, you'll see in italicized strikeout. So the primary change here, and this tied to the committee's discussion on competence, is a new definition, number 2, defining evidence-based practice. And then some renumbering because there's the new definition. The removal of permanent record here, and I'll scroll forward for a moment, and removal of record. And those would be the only proposed changes in the definitions section. So I'm going to scroll back so you can see the new language. And Madam Chair, since this is such a large division, it might make sense to kind of pause and see if there's any questions on each of these sections.
Sounds good.
I think the other thing I should probably do to step back for framing for the board, what's before you today, if you're interested, is if you support the committee's recommendations for these specific rule changes, you could entertain a motion to, once we're through all of the changes, with any edits that you may have, if you moved forward a motion to initiate the public rulemaking process. What that would do is publish a version of this work product out to the community, to licensees, to get their input on the proposed changes. And then you would get that input and be able to make a final determination at a future meeting about whether you wanted to adopt the proposed amendments or not. So with that broad context on this, if there's something that you're not comfortable with as you go through this, or want to see some edits before initiating any kind of proposed change, that would be the purpose of the discussion here. And I think I
Looks
saw,
like Sandra has her hand up.
oh, yep, thank you.
I just
Sandra?
wanted to say that I really like and appreciate the evidence-based practice clarification, and the wording is just, it's just perfect. Thank you.
Thank you. Any other questions or concerns about the definition section or removing the, and we can loop back because it's hard to say about record and permanent record until you've seen it in application in the other section. So I could loop back to that if you'd like, once you've seen the rest of it. Okay. The next section is under general standards for practice. And here's where you see the reference and some clarification on what is meant by competent practice. And you see the reference back to the new definition for evidence-based practice and a little bit of rewording to that language there. Okay. Michael?
I think I know the answer to this, but just reflecting back to the presentations on entrustable practice, activities, and competence, I think that's a concept that's being promoted within the profession, but like there's not been a decision at the federation level, nor a decision by APTA or CAPD. And so my thought is that if the definition of competence is then further clarified by our profession, then we would have the opportunity to revisit this.
Yes, absolutely.
Okay, thank you.
Okay. No changes in healthcare interpreters. So the next change is proposed in 110, general standards for record keeping. And here's where you see the step away from the use of record or permanent record and trying to be more clear, more explicit about what exactly is being meant in each context. So number 2 becomes written documentation shall be prepared on the date service is provided. I'm going to scroll this so you can read the whole number 3. And then in strikeout, as you're reading the new language, that's of course what it says now. And then the bold red is what is being proposed as the change. scroll up a little bit. You'll see the striking of the permanent record and record, referencing documentation, entries. I'm going to move up here.
I wanted to just comment for the RAC that I really love the redefinition of 8 for abbreviations. That's something we look at and talk about all the time as a team where I'm at. And I love that they actually did call out about the individual who is accessing the record should be able to understand that abbreviation, and that is more important than ever these days. So thank you.
And we will be sure to pass that on to the full committee as well, Erin.
That was a big discussion, Erin, that patients now can see their records.
Oh, without a doubt. I mean,
Sometimes before we do, right?
without a doubt, I've had phone calls of people questioning what was written in their medical record while they're in the hospital. And this is just a great way to define that. So really appreciate that.
Okay. The next proposed changes are in standards for authorization. And in this, even though it looks like a lot of strikeout, it's not intended to introduce any substantive change, but only attempt to remove the reference to the 2014 change in the law. And then what we did is move this language up to here, frankly, because the way rules get numbered with the 1 and the A, if we hadn't moved this language up here, we would have had to completely renumber the section, and we were trying to minimize the impact on that. Next change you'll see in still under standards for authorization. Sorry about that. For the record of the authorization. And this is where I was referencing trying to not hold the physical therapist accountable for the actions by the other medical professional, but make clear what was expected or what the PT was being held accountable for. Okay. Standards for initiation. In part 2 here, some of the participants identified that in a school setting, there may be another provider who isn't a licensed healthcare provider, but is fully authorized to be involved in the patient record. And so they did ask for that change. And then a rewording of Part B. And some clarification on C. In the next section, standards for documentation of initial eval. you'll see a replacement of the existing language. And simplified language in the new red text. Some of this was intended, like the number 1, which previously identified patient's full name, age, and sex, rewritten as the patient's identifying information to allow for the fact that in different care settings, there may be different identifying information that's required. And so the current rule language was overly prescriptive or inconsistent with current standards in some settings. Okay to proceed? Okay. And then the rest of this is Michael.
Yeah. So again, thank you. This makes perfect sense reading it. So before, like, part of the strikeout is interpretation of the eval results. And then I think in case, so then we have physical therapist interpretation of the results of the exam, then clinical rationale for therapeutic intervention. And that's kind of a new thing. And I'm not sure how explicitly that's documented in records now. Like when I read something or I write something, I think I'm clear, but I don't know how explicitly we make that. So maybe just a question for the group, like how would this be proven or not proven if there was a concern?
Sherry, I don't know if you or if anyone from the committee wants to speak to that. I can say, Michael, that part of this was to try to leave some flexibility to not be too prescriptive on what that means. So I think it'll vary a little bit depending on setting, and so that the level of detail would probably need to be appropriate to convey the essence of that requirement. But Sherry, do you want to speak to that?
No, I think what you said is exactly right. I think we were trying to make it a little more broad, but incorporate, I think, also what we see required from like payers and Medicare. I'm just looking to see if there's anyone from the committee who's here in the meeting who could speak to it. But yeah, no, I don't have much more to add than that, but I think that's a really good point, Michael. I think that's a point with a lot of things is like, well, how do we, when we look at it, how do we hold somebody to what's there or what's not, what's missing? I don't think of exactly where we took this language from.
I mean, I think of it as patient presenting with blank, blank, blank will continue skilled therapy for blank, blank, blank kind of language.
And I think that's what you see in most records, right? Patient is a good candidate because, needs this, or is a candidate for rehab based on da, 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 da. So I think that's where it comes from. The language came from somewhere. We looked at so many different things in different states and Medicare regulations. But I think the general point was to try to make it a little bit more user-friendly, that it didn't have such specific things that people were having a hard time complying with.
Okay. Yeah, I think that makes sense. And then if something seems really left field, that's when it would be a regulatory concern. Like we can't see from the documentation of the eval why this plan of treatment was pursued.
Yeah, exactly.
Okay. Thank you.
Yeah. Okay. Standards for the plan of care. This is only a changing the language slightly. But then in number 5, next section under documentation of the plan of care, you see the replacement of permanent record with documentation. There was a proposed change to specify instead of treatment, therapeutic intervention in Part B. And then in Part 2, just the change out of for the use of documentation instead of permanent record. The only change in standards for treatment by a student PT or PTA is removing some of the redundant language because this was already defined earlier in the section. Standards for documentation of treatment provided. Scroll it here so you can see it. Part 1 is just a change from record of to documentation of. In Part D, changing the language from treatment to therapeutic intervention. And some requested simplification of what is required for the documentation. In Part 2, some rewriting for clarity, and then also a shift from to the use of intervention, treatment intervention. Next section, formerly known as performing a reassessment, now standards for reexamination. I'm going to scroll up to look at that section. And probably the biggest impact change here is to go from a fixed 30-day to a relative interval from the patient's last visit, which may or may not have been with the physical therapist themselves. Susan?
So I'm trying to, as I read that, I'm trying to understand the difference. And it's just so the 30 days still applies, though. We're not saying it can be longer than that.
The difference is the 30 days can be from the last time the patient had an encounter with what could also have been the PTA. Before it was tied only to a PT.
Okay.
And so this opens it up that if it's been 30 days since they saw anybody, that a reexamination would be triggered.
Okay.
Scroll a little bit more. And this new section for number 4, with the change in the way 30 days is defined, this adds some expectation or some accountability for a physical therapist assistant, that if they identify plateau or significant changes in the condition, or any other change in the patient's condition, that they must request a PT re-examine the patient before they continue to provide treatment. And the reason that the language here is in blue is it's an optional. We had the first time with the rec, we had written out the red language, and then some of the members felt that it wasn't necessarily clear what to do if a PTA is in the middle of a treatment session, if they're able to finish and document what they're doing, or if they have to stop and walk away and aren't able to do anything at that time. And so one of the pieces that was recommended was if it wasn't clear that they could document what they're doing in that moment, to add the past the current session.
I like that.
But just question, so this is saying that like a conversation with the PT isn't enough, that they need to be have a session with the PT before the PTA can continue.
Past that session, yeah. If there's a significant, basically that the plan that was set up has changed, there's some new input that would require the PT to come in and do that examination.
I guess I'm just wondering how this would affect like staffing from a staffing standpoint. Like in skilled nursing, if a PT can't come, but you can have a conversation and you can document the conversation, but then the patient doesn't get any treatment till a PT is available in 4 to 5 days, or, I'm just not sure.
I think that's part of why the couple of committee members were wanting to have the clause about past the current session.
Yeah, I still worry that like maybe in a more rural area where a PT comes every Friday and you can call and speak with them, but then the patient's missing out on sessions. Like if the change happened on Monday, the patient can't be treated at all until Friday, let's say, when the PT is set to come out.
I think part of what they were trying to balance is that it actually is providing more flexibility by allowing the patient to continue to work with the PTA as long as there isn't a significant variation, where before the PT had to do a reevaluation every 30 days. This is just the other side of, if you allow it to go longer, the accountability that if there is a change, that you have to bring the PT back in. So the net effect is actually increasing access for the patient, as long as there isn't a shift that would require the reevaluation.
Right, because the way that it was, there would be a very strict, you can't go any longer than the 30 days. But this gives a little more flexibility unless there's a drastic change in the patient's condition. I think where this came from is cases where there's been a dramatic change or there's something going on with the patient and the PTA keeps seeing the patient versus have the PT reevaluate and reassess what's going on.
I guess I'm still not, like, I not appreciating the difference. And I granted it's just like, it still says that every 30 days, the PT has to do a reexamination. Right? And was that like where it goes back to if it's, so if I did the eval and then the person, is seen by the PTA and then 30 days later, I have to do a reexamination, no matter what, like every 30.
The clock restarts every time the patient, so if you as the PT, right, see them do the initial evaluation, and then they see a PTA every whatever the treatment
Twice a
cycle.
week for the next month.
Yeah, but it can be perpetual as appropriate for the plan of care, right? It's the 30-day doesn't start. It's like if they go in to see your PTA, if you're the PT, the 30 days start from that. But if they see the PTA again 29 days later, the clock starts over.
Got it. Okay, that
Yeah.
part is clicking now.
I think the way that it's rewritten now is if it's the only time it's that 30 days matters is if the patient hasn't been seen by anyone in 30 days.
Right.
All right, so that part just clicked for me, but
Yeah.
then this part, okay, I'll try
Yeah.
it. And so now, saying is that those conversations, like the PTA calling to check in about something, I'd have to actually come do a re-exam in person, not just.
Yeah, that part really concerns me. I just feel like, I guess, what are we considering a significant change? Like, let's say a patient is being treated in skilled nursing for a hip fracture, and then they become really weak and confused. And it's a big change in like their physical ability, but it's because they have a UTI and that's being addressed by nursing, and a conversation with the PT might be enough to continue, but the PT can't come out for 4 or 5 days in a setting where you're supposed to treat every day. I think that just worries me, that part. I don't know if there's another way to word that where there has to be a conversation, a document, a conversation and it's documented. I do understand that, but an in-person, I think that's gonna cause some delay in care.
From the patient perspective, I'm worried about that too, as Erica's talking about.
I think Michael and then Tim.
Yeah, I had two thoughts. One, I kind of wondered about the language or other change in patient status that could result in a change in the goals or the plan. Because it seems like the intent was a significant change. So I'm working with a patient, they had a new stroke. They need to see a therapist to have a new plan to sort that out. That makes sense to me. A PTA colleague saying, the patient's progressing, I think they should have a goal around stairs or community mobility. Are you okay adapting their plan with that progression? Seems like less of a risk to have the therapist physically come, but
Tim?
Eric, I appreciate your concern there. I'm wondering if the PTA contacts a PT about concerns about the change of the patient's condition, it seems that that conversation is deciding if it's clinically relevant or not. And so in that conversation, the PT is making a clinical decision based on understanding that what you've presented as to if a reassessment is necessary. So they are making a clinical decision at that point. So I wonder if that could be implied this way to both satisfy your concern as well as making a clinical decision on the imperativeness of a reevaluation at that time.
I think that's great, Tim. Thank you for bringing that up. The PT could decide at that moment, like, you can continue treating based on our conversation, and this is the plan we're going to do, and I'll be there on Friday. Or say, I would like the patient to be, on hold until I can come out to reassess.
Tim, I think you're on mute.
Tim, I think you were speaking, but you were on mute.
I'm sorry. I agree 100%. You can have that conversation. It would have to be documented as to the outcome.
And I think, Erica, the use of the PTA must request that the PT examine, the committee put forth that language in particular, in part because they wanted to make sure that the PTA was responsibly checking back in with the PT. But I think to Tim and yours discussion right there, and I think that's also why we didn't have the past the current session in the original language, where it was left open. Because if the PTA has requested the reexamination, but the PT doesn't feel that it's necessary in that moment, or before the PTA continues, right, that left more flexibility.
Can we consider thinking about this section more, about how we could incorporate like a documented phone call, or would be okay based on the PT's? I'm probably not using the best words, but based like what Tim was saying.
Yeah, the language doesn't say that the PT has to perform the reexamination. It says that the PTA has to request that the PT perform a reexamination before continuing, right? So that
I took it as it had to happen for the patient kind of be treated.
Yeah, it was just trying to make sure that there is that communication, and that if there's any significant change or any of those changes at all, that there has to be that communication and that request. But the PT could still decide that it's not necessary based on whatever the change of the information is.
Okay.
But yes, even if you were to include this proposed change in the language today, and opened up for additional public input, the final version could still be edited based on that input.
Okay. I think Susan has her hand up.
Yeah, because I guess clearly I'm having a hard time processing this morning, but the language to protect the PTA, like if you're the PTA in that setting and really feel like, no, there's been a significant change, and the PT is saying, oh, it's fine, go ahead and keep treating, but both ways. One, to like, it's okay to keep treating. I don't know, I'm having a hard time with the language in general, so that if a PTA is wanting to not wanting to proceed because of something that's happened, that the PT, I don't know, has to come do a reexamination. Does that make sense? Like both ways, that that you can continue with your treatment if through the conversation it's decided that it's okay to continue and other changes will be made, but okay not to continue if the PTA feels like the person needs a reexamination and doesn't want to continue.
Yeah, I
think my-
agree with what, I mean, so how I'm thinking about this is that PT has the agency and the responsibility to raise things to the physical therapist when there's been a significant change or a plateau. And then it's the physical therapist's duty to determine if an in-person visit or guidance on the phone is okay, and then that would be the point at which like the decision making would be evaluated, I guess, right? So if we're thinking about public protection and protection from bad actors, there's a decision that the therapist is accountable, that the physical therapist assistant has recommended a reassessment. If the reexamination, if the therapist thinks no, then they would need to justify why they made that decision. But they're sort of going against what the physical therapist assistant was asking for.
Jeannie?
Jeannie Thompson. I'm physical therapist assistant, and I participated in the advisory committee. And even as I was reviewing this as part of the committee, I had the same concerns that Erica does, because as a PTA, when I read this, I interpreted it the same way that Erica did. To me, this says stop. To me, this says you can't do anything today because the patient came in with subjective information or you collected objective information that says you need to stop right now. So I understand the intent here, about making it clear that I have a responsibility to ask that question. But I'm with Erica in how can should we clarify the language that says, I've made the request, the physical therapist has heard my request and authorized further treatment for that patient until they are able to see them. I guess my question is, can we or should we be clarifying the language?
Thank you, Jeannie. You have a couple of options here. We can, one of the things that I'm wondering is if language that says something more to the effect that a physical therapist assistant must consult with the physical therapist to determine if a reexamination is necessary before proceeding, language to that effect.
Yes, I think that's sounds good, heading that direction.
Okay. What we could do based on sort of that verbal edit, if you wanted to move forward with publishing something, we could rewrite the language so that it says effectively that to put out for public comment. It doesn't obligate you to that exact language. You could get additional input and still fine tune it through that public process if fundamentally you wanted to move the concept forward. The other approach is that we could remove any change in this section for public consideration now, do more work with the Rural Advisory Committee and bring it back to you in the future. So we could go either of those two paths. If you feel it's close, and if we made an edit based on changing that part of the section, we could move it forward now. But if you're not comfortable, we could pull it and do it in a future section.
I think close. I mean, I think it would be beneficial to get other people's feedback. We have time though. What's our time frame? Can you?
If this was one section in particular that some of the rural clinics were seeking to extend that 30-day, but you're in no obligation to make any rule change. If you wanted to move forward with this edited based on the verbal description, We would publish that. It would go into the Oregon Bulletin to initiate public comment at the end of the calendar month. And then all of the public input would be brought back to you with any kind of proposed changes to the language at your January meeting for your consideration. And then that time you can still either accept or reject those recommendations and make a change or not make a change at that time.
So there's still time if the board goes with whatever they want to do today. Once it goes through the public comment and people, because I've been getting emails about this topic as well, that I've been telling people, we're going to put it out there for public comment whenever the board does that. The board could always rediscuss this and tweak it again after we get public comment from other licensees or whoever, has input, which I think people will.
I think having the time, especially since people are anxious to see kind of what the 30-day part is, I think it would be good to change the language a little bit to what Jeannie was saying, and then go ahead and put it out there.
Okay. Then when we get to it, if you make a motion, if you say as amended, and we will, from the recording, we will make the amendment based on that verbal description. Okay. And then documentation of the reexamination. See the pattern of simplifying and also changing from reassessment to reexamination. Under the standards for discharging, I did reference that the standards for discharge records, there wasn't consensus on, but as far as the standards for discharging, the Rule Advisory Committee looked at and discussed these proposed changes. And you'll see part F is a tie back to competence.
So
Michael?
is the intent of F, the patient has a condition for which I'm not specialized in?
Yes.
Okay.
Mm-hmm.
It is written broadly enough that if for any reason the physical therapist isn't able to provide the care that they need, that's clinically indicated for that individual, Susan?
I'm just like, I'm reading F again, and is it replacing something? Or, I mean, I'm just thinking like, how that's interpreted per like, I don't know, lymph management or something. Like if you're in a rural area, there's no certified lymphedema specialist, but that's something that, like what those entry-level skills or something could be provided, that you're not you can see pediatric patients, you're not a board certified, you know, like just how that could be interpreted by the public, or like, you know, what that, I'm just trying to, was there other language that it's replacing?
It was addressing where it's tied to an extent to the new language that's proposed in B, where a patient desires to continue with treatment where it's not beneficial to the patient, clinically beneficial, or they may want to continue with a particular physical therapist that doesn't feel that they are qualified to continue to provide the care effectively. And tied to that concept of, if there's an expectation of competent practice, that a physical therapist should not proceed with care if they, for whatever reason, aren't able to provide it.
Okay. I guess I'm still struggling with that like language, like in, I mean, I'm obviously all for the evidence-based practice language that's been put in there. And I've got a lot of different sort of maybe worst case scenarios in my head, but yeah. I'll just
Maybe just to
Susan?
tag on, I don't know if we're thinking about this the same, but could you expand on for any reason? I guess in the back of my head, I'm kind of thinking about abandonment and just wanted to be clear that, you know, where's that line?
I do think, Michael, that's where what we were trying to address here, the abandonment, or when a patient wants to continue and the therapist doesn't feel it's either appropriate or not safe to do so. And if, you know, when can you discharge a patient in those situations? And the best language to use for those.
Gary, that helps. Like, the therapist feels not appropriate or not safe to proceed. And that almost to me seems clearer than sufficient evidence-based care.
yeah, I think that sounds.
And I guess if you said not safe, it could, you know, that could mean a couple different things too, for the patient or for the therapist.
Just to clarify, I think what Susan and Michael were kind of saying is that if the concern is that if the therapist doesn't feel like they specialize in something, that they might, what is evidence-based? Are they qualified enough and just be fearful of treating the patient, which
Right,
would
like,
result in the patient not getting care?
Right, I can't treat you because I'm not a lymphedema certified, right? My Practice Act now tells me I have to discharge you because I'm not a specialist in that. I'm, you know, so that's, I guess, you know, that piece is what, thank you for sort of putting those more words out there.
Well, I think your Practice Act already says that you have an expectation that in standards of practice that if you're practicing, that you're practicing with sufficient evidence-based care, or that you shouldn't be treating patients. You've already said that earlier in the section. What this is saying is that for whatever reason in this moment, and it was left broad from the idea of competence or discompetence can be driven by a number of factors, not just your knowledge and skill, but it can be situational. If you don't feel that you are competent to practice in that moment, that the expectation is that you don't treat and that you discharge the patient if there's no way to transfer them to somebody else, rather than treat them anyway. So it's not intended to set a standard of a specific certification or number of hours of training or anything like that. It's still a relative condition, but it was trying to tie that, tie back to that standard of treatment. But it is something, if you're not comfortable with the language, it can either be pulled out. This section in general could be combined with the standards for documentation of discharge. And you could ask the Rule Advisory Committee to spend more time on both of these sections.
Michael,
Or-
what was it that you said is not safe or something to continue?
Well, yeah, I was just quoting Sherry, but yeah, so, not appropriate or not safe to proceed. So it'd be sort of like the
And
physical
maybe,
therapist,
yeah,
for any reason, if the physical therapist determines if for any reason it's not appropriate or safe to proceed, and the
based
therapist,
on evidence-based practice, there's something different.
yeah,
To me, there's something in that language that the therapist cannot provide sufficient evidence-based practice versus it's not safe or appropriate to proceed based on evidence-based care. I don't know why that's sufficient. I think it's the word sufficient. I don't know why.
I hear what you're saying, but it was more than just, is it safe or appropriate? It was, are you competent in that moment as a provider to be providing care? And if you're not, then you shouldn't be providing treatment. So I think, oh, and I'm sorry, I didn't see your hand, Tim.
I would like to just say that remember, evidence-based care includes the clinician's competence and experience. So if we're talking about safety, we can actually go back to the definition of evidence-based care, and that would actually allow safety to be brought in based on that clinician's experience and competence.
Mm-hmm.
So it may not have to be specifically written out as safely providing care if we use the definition of evidence-based care.
Okay. Sandra?
I was wondering if you could give an example, Michelle, of some of the things that you're thinking about that I feel like you're alluding to, but I'm not quite, I'm not being able to think of an example.
Well, and I'm trying to represent the discussion of the committee more broadly. And it ties back to the concept that's been brought up with the Federation and with the APTA as well, about the idea of discompetence instead of incompetence, but that there can be factors that are situational or that change over time. Burnout is an example that the practitioner may not feel that they can provide the level of care that the patient needs, not because they don't have the clinical background, skills, and training, but that they're not able to provide the level of care in that moment that the patient needs. Instead of proceeding, because that's their workload or something else, that they are expected not to treat. And that this is saying it's okay if you're not able to provide the care that the patient needs to discharge the patient. As opposed to now, there's the expectation that you don't have a choice as a practitioner. So that's what it was trying to get to encourage folks to be self-aware, both from the standpoint of making sure that they have the clinical competency, skill, education, training to do it, but at a relative level appropriate for that patient. But also if there's a situation where, and that gets into what Sherry was describing as safely practice, right? For whatever reason.
I'm curious, I have two things. I'm curious if just the word sufficient was removed, if that would still have the same intention, and then maybe to the point of Susan, that concern about people abandoning, I don't know. And then my other proposal is that we take a break.
I was thinking the same thing.
Okay to recognize Sandra before?
Yeah, of course. Yeah.
Just wondering if that's opening a door for a therapist to be able to abandon a patient for just very prejudicial reasons or not. Because of a bias or because they don't like him or something like that. I just throwing that out there when we're trying to address unconscious biases that we have, if that kind of opens that door in a different direction than what we want. Just a thought.
So Madam Chair, what I would recommend before the break is to think on one of the options is that F can be removed entirely from the draft to move everything else forward. Or we can just pull all the changes from this section on standards from discharge at this time and ask the RAC to noodle on part F a little more based on this discussion, and then bring it back to you in January when they bring the standards for discharge records as well. And then how long would you like for a break?
10-minute break. And that was not your first question. How do people feel? Should we have this kind of taken back and worked through a little bit more?
I just threw that out there for you to think about during the break.
Think about.
Answer
Okay.
it. Answer
Got
it.
Okay. Thank you, Michelle. Okay, so we'll take a 10-minute break. The time is 10:16 and the Oregon Board of Physical Therapy is in recess.
Okay.
The time is 10:26 a.m. and the Oregon Board of Physical Therapy is back in public session.
So before the break, there was discussion on part F, introducing the new language, which I think is fair to say, at least as written, isn't quite getting to what the Rule Advisory Committee had discussed. So a couple of options on this section that we could do at this point is you could strike F entirely and move forward with the edits otherwise. Or you could move forward with it the way it's written and then see what other input you receive through the public process. Or the third option is that we just don't introduce any changes for this section 165, and that you hold it and ask for the Rule Advisory Committee to spend more time on part F and bring it back to you when they bring 170, the standards for discharge records, at your January meeting. So we can either pull out part F entirely and move forward without it, publish it as is if you want to move forward with rulemaking to get public input with that as a starting point, or pull the whole section and have that come back to you.
If we just move forward to get things, to keep things kind of the momentum going, that that doesn't mean that it couldn't be completely reworked during that process, right? Or do you have to post it again?
It depends on how much of a departure it is. If the feedback and the revised language is within the way it's framed when it is published the first time, you can make those edits. If it's very different, then you'd have to renotice it. I think my recommendation would be either to remove Part F entirely, if you want to move this section forward, or since you're already waiting for Part 170 standards for the discharge records, it would make sense to hold standards for discharge and look at those two together.
Any thoughts either way?
One
Hey,
of the things,
oh.
I'm sorry.
Oh, no, you go ahead, Michelle.
Hauku was gonna say something.
Well, maybe what Michelle has to say will change my mind.
Well, and I was gonna ask Jeannie or Sherry, in thinking about what the discussion was that led to the proposal of Part F. It may not be necessary, that it may be enough that that standard for care already says that if you're not competent to practice, you shouldn't practice. That maybe this is actually an unnecessary add into standards for discharge that is unintentionally creating some of the concerns that have been raised here. But I don't know if Sherry or Jeannie, kind of from the discussion, if you have thoughts on that.
This is Sherry. My thought is that I do think what's already in language covers like the section that talks about with the experience and skill and all that, covers when you can't see a patient. But I don't know that this, I do think we maybe could tweak this a little bit to cover the situations like some of like the language that Michael was bringing up, because I think, you know, what we don't have is a rule about abandonment. And I think maybe we were trying to cover that here, that maybe that's not coming through. So I personally think if the group's already looking at that whole other section on discharge, it kind of might make sense to look at the whole discharge all at once, since it's, you know, when we first crafted these rules, however many years ago when I first started, you know, we really purposely had like the rules sections together, like the standards for discharge, and then the sections for discharge records, and the standards for evaluation, and the standards for the record of the evaluation. So it makes sense to me, if the committee's already going back to look at the discharge records, that we go back and look at the whole, all the discharge rules together.
I'm seeing Jeannie thumbs up from a rule committee member. Hauku, does that change what you were going to say?
No, what I was gonna say was that it seems like, for the sake of like tidiness, to keep it all together and the discharge. And I have maybe more questions, not specifically, but I just would like to hear more about abandonment, and kind of like maybe expand that conversation at some time so that I can contribute more to this conversation, because I think I'm not up to speed on that. So maybe like for me, maybe digging into that whole discharge section a little deeper would be helpful.
Okay. So if what I'm hearing then is that we would amend the proposed rulemaking to remove all of these changes so that nothing would move forward from this section. And that would come back to you with 170 after being brought back to the Rule Advisory Committee. And that you would also like to direct them to discuss and bring back time to consider the concept of abandonment in more detail. Erin?
Yeah, I agree with that. And I would just say on the concept of looking at abandonment, like might be helpful to look at what physicians do or other disciplines, because it's literally not solely, of course, just a physical therapy. So I am curious how other boards address it.
Okay. And I do believe that as the amended for any motion, there would be no changes in 0165. And there are no other changes in Division 40 that are coming to you from the Rule Advisory Committee at this time. So just scrolling to show that. But before you would be the option, if you are interested in moving everything else forward, then you could entertain a motion to move it forward to initiate the administrative rulemaking process as amended. And that would be the removal of 165 and then the adjustment that was made in the prior section on re-examination. Hoku?
Like a motion, Madam Chair?
Oh, real quick before the motion, I just wanted to say a thank you to the Rules Advisory Committee. This is like eye-crossing work, you know, which you can tell by this conversation that we're just like every little word matters a lot, and it's a lot of jargon to work through, and so I just feel really thankful for all the folks who went through this with a fine-tooth comb.
I would absolutely echo that. And this is a group of folks that did this probably at least 4 or 5 times, going through line by line. I think there were 3 or 4 different meetings plus on their own work. I mean, just a tremendous group of people that put a lot of their experience and heart and soul into this. So a good group to work with.
I agree. I want to thank Michelle too. Michelle put a lot of time and work into what it takes to write out this stuff with the cross outs and the bold and all of those things is really tedious and time consuming.
Okay, do we have any motions?
We do, if you're ready.
I'm ready.
Okay. I move to direct staff to initiate the administrative rulemaking process related to OAR 848 Division 40 as amended.
I second the motion.
Motion is moved and seconded. Roll call vote. Timothy?
Aye.
Erin?
Aye.
Sandra?
Aye.
Hoku?
Aye.
Michael?
Yes.
Susan?
Aye.
Erica?
Aye.
Dwight?
Aye.
Madam Chair, the motion carries unanimously. Madam Chair, would it be okay? We have 2 more rulemaking pieces, much shorter. Would it be okay to proceed with those and then go back to the?
Yes.
Okay. The next one is a rulemaking that's already in process. You had previously initiated the administrative rulemaking related to the Physical Therapy Compact Commission rules. It is a process because of the compact statute and the Oregon Constitution. Anytime the Compact Commission changes rules, this board has to review it and adopt it into Oregon rule in order for it to be effect. These were published and open for a public comment period. The only change was the version of the rule highlighted in red. There was no public comment received. And so before you today is the option of a motion to adopt the proposed amended rule.
I move to adopt the proposed rule amending OAR 848-055-001 as written to be effective on filing.
I second the motion.
Moved and seconded, roll call vote. Timothy?
Aye.
Aaron?
Aye.
Sandra? Sandra?
Yes.
Hoku?
Aye.
Michael?
Yes.
Susan?
Aye.
Erica?
Aye.
Dwight?
Aye.
Madam Chair, the motion carries unanimously. The next item, rulemaking amending the section on board member compensation. This was a result of a statutory change in a recent House bill, and which tied compensation to the federal per diem. Based on legal advice that was received, some of the way the board member compensation worked previously isn't consistent with the changes in the statute. This was done previously as a temporary rule to put it in place immediately. There was followed up with rulemaking to make a permanent rule change. That was published. There was no public comment received on the proposed permanent rule. So before you would be the option of adopting the proposed amendment as published.
I move to adopt the proposed rule amending OAR 848-005-005 as written to be effective on filing.
I second the motion.
So moved and seconded, roll call vote. Timothy?
Aye.
Aaron?
Aye.
Sandra?
Aye.
Hoku?
Aye.
Michael?
May I abstain?
Yes.
Thank you.
Susan?
Aye.
Erica?
Aye.
Dwight?
Aye.
Madam Chair, motion carries. What I'm going to do at this point is scroll back to page 28 of the packet. Just a very brief update. The board did some preliminary work at the September meeting on updates for the strategic plan. We have the information from your discussion, and our intention is that we would have another session during the presumed January meeting for you to further discussion and do the next step in the strategic planning process. And on this section is for roundtable for board members or discussion, introduction of future agenda items that you would like to see at an upcoming meeting. Sandra?
Is this where we would ask or talk about implicit bias and how we might be dealing with that?
This would be a section that if there's any topics that you want to be able to discuss in public session at a future meeting, because we have to be able to notice any topics ahead of time. So yes, you could introduce that you want to have a discussion on implicit bias, and then we would schedule that for a future meeting.
Okay. I'd like to do that.
Okay. Any others?
The abandonment topic that came up earlier.
Okay. As a general discussion?
Yeah, like, I mean, some, like, as Erin was saying, like what other boards and how they view that, what those definitions are.
Okay. So, so to have staff do some preliminary work to determine how other health boards are handling that and bring those to you?
Yeah.
Okay.
Please.
Sarah?
Yeah, I wanted to just mention that earlier this week, the state of Oregon held a data equity summit, which they expected about, you know, an optimistic attendance was going to be about 100 state of Oregon employees. And they had over 1,000 people register within the state. And so those sessions are going to be available soon, hopefully, I believe in Workday. And so there's going to be potentially, I was clocking as the different sessions went on, like, ooh, I bet Michael would be interested in this one. Ooh, I bet Hoku would be interested in this one. So I might send some of those out. But I think that as this is something that is clearly there's a lot of interest within the state at kind of a more grassroots level among staff. And so we might see some things coming out of that. We discussed potential changes to Real D coming up. And so I just wanted to throw that out there. If there's anything along the lines of data equity, I'd love to discuss that more and send that out to you guys, because it was really a very fascinating 2-day 16 hours on Zoom that I got to experience. So just a brief plug for that, and would love to talk with you all about that more.
Would that be a topic that the board would be interested in having us bring forward at a future agenda?
Shocking that Hoku raised her hand.
Okay, and I'm seeing general head nods. Thank you, Sarah. Michael?
What's the group think about informed consent? And so it's my rationale is if a definition is coming out of the FSBPT committee and has like several requirements in it, a discussion around like what's our current state with informed consent, and then what is the proposed definition, and what should we do about that, and then I think there's this public awareness piece too. What should be our role in disseminating information to the licensees?
Okay. Other topics? I know previously we had mentioned bringing back information relative to student debt trends in some of those publications, and also artificial intelligence and regulation. So we could add those topics to future agendas as well. Okay.
This is Hoku. I have a not fully formed thought, and usually, like, if it's not fully formed, I don't say it because I can't make it sound coherent. But I'm gonna try. In the last meeting we had, there were cases brought up for investigation Yep, never mind. As it's coming out, I'm hearing the problem.
Okay.
Thanks.
Other topics? Okay. And I think I had mentioned at the September meeting that we're also looking to schedule the Oregon Ethics Commission, who now has responsibility for public meetings law, to come in and be able to do a training for board members. We don't have that scheduled yet, but that would be another topic, is public meetings law, that would be on a future agenda. Okay. The last item on today's agenda, unless there's other business, is speaking of future meetings, is for the board to consider the 2025 board meeting schedule. The proposed dates and formats would be as follows. Similar to 2024, with during Zoom, over 2 days, the executive session and public sessions for January, March, and November, proposing in-person meetings for May and September, which would be both executive and public session. And then a shorter meeting in July that would be both the executive and public sessions, just the 1 day, probably under the 4 hours. For your consideration, we will need a motion to adopt the proposed schedule. Of course, it is subject to change as things happen throughout the year. Should something come up later, but this would be what would be published on the website for upcoming meetings for 2025.
Wanted to clarify, July would be virtual.
July would be virtual, yes.
Thank you.
It's a little bit different than the pattern we've had in the past, and part of the special says it's on a Wednesday, not a Friday morning, and for both sessions, and part of that, frankly, is being influenced by when the Federation Leadership Issues Forum is scheduled, to try to avoid conflicts there.
Are you ready for a motion, Madam Chair?
Yes.
I move to adopt the proposed 2025 board meeting schedule as written.
I second the motion.
Moved and seconded, roll call vote, Timothy,
Aye.
Aaron,
Aye.
Sandra,
Aye.
Oku,
Aye.
Michael,
Yes.
Susan,
Aye.
Erica,
Hi.
Dwight.
Aye.
Madam Chair, motion carries unanimously. Next order, if there is any other business from prior agendas or any other from past meetings. Madam Chair, we do not have any for you from staff that I'm aware. And if no other business, then just to highlight that the next public board meeting would be in January 2025, and we will have the latest schedule that was just adopted by the board published on the board's meeting pages.
Okay. The time is 10:53 a.m. and the Oregon Board of Physical Therapy is adjourned. Have a good day, everybody. Thank you.
Thank you, everyone.